Welcome to the Lymphoma Research Foundation's update on relapsed refractory chronic lymphocytic leukemia, small lymphocytic lymphoma, CLL/SLL. My name is Jimena, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete the evaluation of this program. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I am pleased to introduce Hope Avalon. Hope Avalon is the Program Manager of Patient Education at the Lymphoma Research Foundation. Welcome, Hope.
Thank you, and thank you to everyone for taking the time to join us on today's update on relapsed refractory chronic lymphocytic leukemia and small lymphocytic lymphoma. We'd like to first thank our sponsors of this webinar, AstraZeneca, Genentech, and Merck. And before we begin with the program, I'd like to share some information about the Lymphoma Research Foundation. So we are the nation's largest nonprofit organization that focuses specifically on lymphoma, and our mission is to eradicate lymphoma and to serve those touched by the disease. All of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. And in addition to today's program, we do also have a variety of other programs and services available for you. So one example is our LRF helpline, which serves to complement our patient education programs like this one. The helpline has master's level trained staff who provide individualized information on all subtypes of lymphoma, as well as information on treatment options, clinical trial navigation, and connection to resources such as financial assistance. We also do offer a peer support program called the Lymphoma Support Network. And through the Lymphoma Support Network, we can connect patients and caregivers with others who've been through similar experiences for emotional support. And in addition, LRF also has comprehensive disease guides and fact sheets, which can be ordered or downloaded on our website, which is lymphoma.org. We also offer a variety of other in-person and virtual educational programming so that you can continue learning about the latest updates throughout the year. And finally, we do have a wonderful program planned for you today, and I'm so honored to introduce you to our speaker, Dr. Maziar Shadman. Dr. Shadman is an attending physician in hematologic malignancies at Fred Hutchinson Cancer Center, where he's also an associate professor in the Clinical Research Division. Thank you so much, Dr. Shadman, for speaking at our program today, and I'll now turn the talk over to you.
Thank you, Hope. I would like to thank Lymphoma Research Foundation for this great opportunity to talk to patients and their families directly and have a chance to have a Q&A at the end of this presentation. So what I'm trying to do today is to kind of briefly talk about what is available in terms of our treatment options for CLL. And then first I start by reviewing some principles when we have a disease that's now returned, and usually the conversations that I have with patients in the clinic, I try to summarize some of the initial principles, and then what I'm doing today is to talk about first the standard of care therapies, drugs that are approved by the FDA for treatment of CLL, different scenarios where what treatments have been used in the past and what it means for future, because the most important factor in making decision regarding future treatments is what patients had in the past. So we'll try to review that. And then we have in recent months, in the past 2 months, we had two very important publications about two new treatment modalities. One, a CAR T product, and the other one is a novel targeted drug that hopefully will be available for patients with CLL in the relapse setting. And I'll try to talk about those two drugs, and then we'll finish by summarizing some of the important clinical trials that are ongoing. And of course, we use a few examples. But just to start, this slide shows the medications that have been introduced to our treatment toolbox in the past, I would say 10 plus years. We started with, back in early 2000, we only had really chemotherapy options and anti-CD20 monoclonal antibody rituximab, and really starting 2013, 2014, newer drugs, the next generation CD20 antibody obinutuzumab, followed by really the revolutionary drug Ibrutinib in 2014, followed by idelalisib, and then in 2016 Venetoclax, which was another game changer for CLL. And then later in 2019, a Calabrutinib, a next generation Bruton tyrosine kinase inhibitor, was approved, and more recently Zanubrutinib, another second generation. So, I mean, when you look at these drugs, the number of just the new agents that are available and the pace of approvals is really uh, amazing. So many great options for patients, but the question is how to use them and how to sequence them. So, especially in the relapse setting, we'll try to cover some of those. So very briefly, just to give you an idea of how these drugs work, and I don't have a pointer for this slide presentation, but I'll try to kind of walk you through this slide because I think it's important to know how these drugs work in very basic, basically language. So if you look at this cell in the middle, that would be a CLL cell or a cancer cell. And we have different ways of attacking this cancer cell. The two cells on the left and right are normal T cells. These are immune cells that our body uses or has to fight infections primarily. And these T cells sometimes help with the prevention of cancer, and sometimes when there are early appearance of cancer cells, the immune cells are able to get rid of them. But unfortunately, for patients who have active CLL, for example, these T cells are obviously not doing a great job. Otherwise, CLL would not be a clinical problem. So recently, we're trying really novel approaches to get the immune cells or these T cells engaged and kind of get their help in fighting cancer. Unlike other types of B-cell lymphoma, CLL is a little bit behind, but what I will show today is a very promising data for CAR T cell therapy or chimeric antigen receptor T cell therapy. It's a novel way of kind of utilizing T cells and training them to attack CLL cells. So, starting from the left side, that would be the CAR T therapy. Basically, we genetically engineer the T cells and we kind of guide those T cells to fight the CLL cell. We'll talk about it in more detail, but I'm starting from the left side where it says chimeric antigen receptor. It's currently not an approved treatment for CLL, but hopefully in the near future. Moving to the top part of the slide where it says B cell receptor, this is the engine for the CLL cell. This is the engine for the cancer cells. And when you see below that area, there you have a small kind of circles indicating different names of different enzymes. And please pay attention to the one BTK or Bruton tyrosine kinase. This is a very important enzyme that's very critical to help the cancer cells engine continue to work. So if we have a way to stop that BTK, we are able to kind of stop the CLL cells from growing. And that has been the principle behind using drugs like Ibrutinib, Calabrutinib, and Zanubrutinib, as you see in this box. And more recently, we have another type of drug that also inhibits Bruton tyrosine kinase enzyme in a different way, and that drug is called Pier2 and I will mention that it's another promising drug and that hopefully will be available. Now, and then on the top, you see the PI3 kinase inhibitors. This is a class of CLL drugs that we still have available. These drugs are associated with high toxicity rate, unfortunately, and we don't use them unless really we have to. And we definitely don't use them in the first line setting. We try not to use them in the second line, and more recently with more drugs that we have available, we're trying to push these drugs, idelalisib and duvelisib, to the later lines of therapy if we can. Right in the middle, or maybe a little bit lower than the middle part of this cancer cell, you have the BCL2. That's a very important target for a very important drug for CLL called Venetoclax. So in a way, this drug induces death in the cancer cell. It basically tells the cancer cell that it's time to die. And this is a very important way in our cell biology, that all our cells in our body, normal or cancerous, they have a programmed death. They have a plan for dying. And in cancer cells, what happens, this plan won't work. So cancer cells kind of start not following that command of like dying. And what this drug does, kind of reminds the cancer cell that, hey, it's time to die. So venetoclax is an important drug that by targeting that BCL2. And I will tell you very briefly at the end that there are new versions of venetoclax, or next generation drug in this family, that we're trying in clinical trials now. So that's another important update for you. And then just pay attention for a second to the lower part of the slide where it says bispecific antibodies. The box that, if you pay attention, it also tries to get the T cells close to the cancer cell. And just another way of having our own immune cells in the fight with CLL. And this is a very promising class of drug for B-cell lymphomas. In 2023, we have approval of 3 drugs that have been approved for different types of B-cell lymphoma, including follicular lymphoma and large cell lymphoma. We don't have anything approved for CLL yet, but there are clinical trials that are ongoing, and in the last section, I will briefly talk about that. So, the point of showing this slide is that we are attacking cancer cells in very different ways. We are using T cells. We either change the T cell and train it to attack CLL cell, or we may use a drug to bring the T cells to the cancer cell. We target the engine. We try to turn the engine off. And we also use drugs that kind of induce death in the cancer cell. So really, the reason why we started thinking about combining these drugs is the fact that they work very differently. So you take advantage of more than one way of killing the cancer cell. And fortunately, the side effect profile of these drugs are different. Therefore, we are able to combine them together. It's not like they're all, let's say, impacting the kidney. So you're limited in like adding another renal toxic drug to the other one. We don't have that. Fortunately, these drugs are different in terms of their safety profile too. So that gives us the opportunity of combination therapy, which is future for CLL, and we have many clinical trials. And I will show you one example. So with that introduction, let's move to kind of reviewing some principles. Remember, CLL or SLL. By the way, this talk is about CLL or SLL. This audience knows that these are 2 ways of presentation of the same disease. So when I use the word CLL, everything that I talk about today applies to SLL, but I will use the word CLL just for practical reasons. So CLL is not a curable disease, meaning that despite the fact that we do a great job in treating it and we can put it in remission, and the remissions last for a long time, the disease by definition is always likely to come back. So we don't think that we can cure CLL like some other lymphomas, that after 5 years, if the disease is not back, we kind of discharge the patient from the cancer clinic. They don't need to see us. We don't have that with CLL yet. We're trying to get there. But at the moment, we do expect for a CLL patient to be a lifelong kind of uh, uh, patient, and to have a relationship with the physician, because there's always a chance for their disease to come back. So it's not surprising for a CLL to return. This should not cause extra stress than what a cancer patient already has. So the fact that the CLL comes back after 5, 3, 4, 6 years, it's not a great thing, and of course needs to be treated and a lot of discussion. But don't look at it as a reason to believe that your cancer is riskier than other CLL. So that's the nature of CLL. It will come back. And but it's important to take to account the timing of that relapse. I mean, it's a different thing if you start treatment and 6 months later disease starts to grow again, or uh, versus someone who has finished a 1 year of therapy, for example, with let's say Venetoclax and antibody for the first line, and then they have their disease coming back 5 years later, or maybe 1 year later. So these are important factors that we really consider when we are thinking about the next line of therapy. As I said, prior treatments are very important, of course, because we don't want to repeat a treatment that didn't work in the past. We don't want to repeat similar drugs. So it may not be the exact same medication, but there are medications that work the same, and their resistance mechanisms are the same. So it doesn't make sense, for example, I give you an example. For example, if somebody was on Ibrutinib in the past and their disease after 4 years started to grow on Ibrutinib, it doesn't make sense to give them, for example, Zanubrutinib, because these drugs kind of work similarly. So these are important discussions to have. And of course, we always consider patient factors and logistical issues, comorbidities, what other medical conditions they have. And we also look at the disease characteristics. Every time at the time of relapse, we need to make sure that we have a good understanding of the molecular signature of the cancer, because it changes. With CLL, over time, cancer cells can gain or can lose some of the genetic markers, and that could translate to their clinical behavior. So it's very important that every time that we are dealing with a relapsed disease or a disease that's now active again that requires treatment, we need to have a good understanding of what exactly we're dealing with. What mutations are there? Are we now having a high risk chromosome change or high risk mutation that may change our treatment strategy? And I kind of mentioned that if you look at the blue box, which is the treatment duration, if a relapse happens during the treatment, it's one thing. If it happens a little bit later, is another scenario, and if it happens much later, that's a whole different situation. So not all the relapses created the same, and they need to be really discussed very closely with your CLL physician. Also, a quick reminder that having a disease progression doesn't necessarily mean that we have to initiate treatment immediately. So let's say we have a patient who had chemotherapy long time ago, and 7 years ago when chemotherapy was still I think, in CLL. And now their lymph nodes are slowly growing. Now, over the past 6 months, they're feeling some lymph nodes that are palpable in the groin area. Does it mean that they need to be immediately started on treatment? And the answer is no. It's very similar to when we have a new diagnosis, right? I mean, for many of the patients, they're familiar with the watch and wait strategy. The disease can come back, but it may take a while before it requires treatment. And so just need to report and kind of discuss it with their physicians. But for many patients, there's a long time between having that progression uh, until they actually require treatment. Now, for example, if somebody is on continuous therapy with a Calabrutinib and they start having a lymph node, that's a whole different situation. Watch and wait in that setting is not reasonable. I was referring to the situation where patient is not on any active treatment. So they have finished their treatment a long time ago and they have reappearance of their lymph nodes, or their blood counts start changing. Some of those patients can be observed, but if you have progression of disease while receiving active treatment, that's a very different situation, and needs to be dealt with immediately. Uh, no need to say that internet and social media are great, but they're not they should not be your main resource to gain information. It's heavily biased by a lot of factors. When you search for something, you have to use very reliable and unbiased and scientific resources. And I would say nothing really replaces a discussion with a CLL expert. That every CLL patient should have a CLL expert, if not as their primary physician, as someone whom they can contact and like find every maybe a couple times a year. I mean, if you don't need treatment, you don't need to see them, but maybe once a year have a discussion and make sure you are updated on what's going on in the CLL field. if you don't live close to a major academic center or close to a place where there is a CLL expert and you're being treated by your local hematologist or oncologist, that's perfectly fine. But make sure the plan is reviewed by someone who is more familiar with the CLL. And many of us are focused in one disease or small number of diseases, and we try to kind of and these conversations are helpful because you do want to take advantage of all these advancements that I showed you in the prior slides. And oncology is a very rapidly changing field. uh, a colleague who sees all kinds of cancers, and they do a great job in treating different types of cancers. um, Nobody expects them to know all the details about, for example, CLL, which is not the most common type of cancer they're dealing with, right? But I mean, getting that second opinion from a CLL person and then having that uh, treatment given by a physician locally, that's perfectly fine. But just want to make sure that you take advantage of all the advancements. And consider clinical trials. Clinical trials are not just helping others and helping the field, which are very important, but clinical trials most of the time these days also benefit the patient uh, by just having access to new drugs years before they become available. Some of the data I will show you, for example, in our center, we have patients who have been benefiting from these drugs 5, 6, 7 years before the data even becomes available, before the drugs are even approved by the FDA. So that's how basically um, I'm sorry, I got distracted. I thought I saw a message for me, but that's how we kind of try to take advantage of the newer drugs. CLL being an incurable disease, we need to be smart and we need to take advantage of any drug that is available or any promising drug that is not yet available, at least publicly. So, quick reminder for I mentioned that not everybody needs treatment, but who does need treatment? Patients who have low blood counts, or they have large lymph nodes, or they have symptoms related to CLL. I think most of our patients are familiar with that. I'm not spending much time on it. So what I'm doing today, just discuss very quickly what are the standard treatments that we could use in the relapse setting and review some of the recent data about some of the new drugs. Then I think there are two expected FDA approvals in the next year or so, I hope. We'll discuss those two drugs and then some examples of some promising and ongoing clinical trials that I will review. Now, let's start with the scenario that we have a patient, for example, who had bendamustine rituximab 7 years ago, or 5 years ago, or 4 years ago, and they achieved a remission. They're enjoying their life. 4 years ago, finished the chemotherapy. Maybe 7 months ago, I started feeling some lymph nodes. They talked to their physician. The decision was to kind of watch that and pursue a watch and wait strategy. But now the lymph nodes are growing, they're having symptoms, they're tired, and their blood counts are also different. So basically, the decision is made to now offer treatment. So this is an example of a patient who has not received any of the novel drugs for CLL. They've only had chemotherapy. And the good news is that they have two important classes of CLL drugs that they can use. And I would say no CLL patient should go to the third line without having either BTK inhibitor or Venetoclax. And what I'm going to do very briefly here is just to review these two classes. Again, very quickly look at the red box around the BTK inhibitors. And I talked about this at the beginning, but I don't want to spend more time. But probably the most important class of CLL therapy is BTK inhibitor and are BTK inhibitors. And um, the there are three covalent BTK inhibitors. Covalent means that these drugs attach to the enzyme in a way that they kind of don't let it go. It kind of they attach to the enzyme and they just remain there and inhibit it. And we have three drugs in that category. We have Ibrutinib in the middle, which was the first drug in this class, and it was amazing in how it changed the field. Multiple clinical trials showed that Ibrutinib was better than chemotherapy. And the problem with Ibrutinib was that despite the great efficacy, it was also um, it came with some toxicity, and patients had problems ranging from having muscle pain or joint pain or sometimes having skin problems, nail problems. And these are things that most patients were able to deal with and still remain on the drug with some dose adjustments and sometimes dose interruptions and things like that. But there were also other problems like atrial fibrillation. Every once in a while, there are reports of major cardiac issues like sudden cardiac death. Thankfully, these are not very common, but it's important even if it happens in one patient. And so then the idea was to make similar drugs to ibrutinib, but I would say cleaner versions of ibrutinib. So if you look at this kind of picture here, it's called kinome map. And what it shows that what is the target of ibrutinib in the blue circle. And then all the red circles are other targets that ibrutinib also inhibits, and it's not supposed to. So we call them off-target events. I'm sorry, off-target enzymes. So what happens when you go for targets that you're not supposed to be going for? You cause side effect, right? So some of these targets led to atrial fibrillation. Going for some of the other targets led to bleeding problem with ibrutinib. So if you look at the two other drugs, zanubrutinib and calabrutinib, they're much cleaner. So you see smaller red circles and you see fewer red circles. It means that while the drug zanubrutinib or calabrutinib, while they target what they're supposed to target, the blue one, you see fewer red circles and smaller red circles. So that's why these drugs are cleaner and they became available. And over time, we had multiple clinical trials that led to the approval of both drugs for patients with CLL. Now, recently, meaning in the past few years, we had clinical trials that showed that either acalabrutinib or zanubrutinib are better than ibrutinib. I think the point I'm trying to make here that in 2023, we should not have the if BTK inhibitor is the choice, which is the choice for many patients, we should go with either zanubrutinib or acalabrutinib and not ibrutinib because these two drugs are better than ibrutinib from the safety profile. And in a study with zanubrutinib, we also saw that the drug is actually working better in terms of controlling the CLL compared to ibrutinib. So, I mean, the one line conclusion for this slide from me, or maybe from this talk, is that no patient should be starting on ibrutinib these days. We have better drugs, either acalabrutinib or zanubrutinib. The study that looked at zanubrutinib versus ibrutinib in the head-to-head setting, a randomized clinical trial that patients got randomized to either receive ibrutinib or zanubrutinib. Patients with zanubrutinib had fewer side effects, specifically cardiac side effects like atrial fibrillation were less common, and more importantly, zanubrutinib provided better disease control compared to ibrutinib, which was an important finding and led to major presentations and publications late 2022 and early 2023. And I should say that some of the side effects on this study were not different. For example, hypertension, the rate was not lower with zanubrutinib, and patients who had zanubrutinib had a higher rate of neutropenia, meaning that their white blood cell count was the rate that the number was low was higher with zanubrutinib, but they didn't have higher rates of infections. So this study told us that zanubrutinib is definitely better than ibrutinib, both from the safety standpoint and also from the efficacy standpoint, meaning that controlling CLL better. There was a different study in yellow color compared acalabrutinib to ibrutinib. This study also showed that acalabrutinib is much better from the safety standpoint. The side effect profile was superior and in favor of acalabrutinib. In this case, even hypertension was the lower incidence with acalabrutinib versus ibrutinib. And this study, there was no difference in terms of how good the drug controlled CLL compared to ibrutinib. Basically, the conclusion was that it's not worse than ibrutinib. It's at least as good. But again, these are different studies. Please remember that zanubrutinib and acalabrutinib have not been compared head to head. So this is an indirect comparison and between different studies. But it's important to also show you that, for example, this is a study that compared ibrutinib to acalabrutinib in blue color, and ibrutinib in the yellow color. And as you see, basically, I mean, this is called the Kaplan-Meier curve, and it shows the number of patients who relapse over time. And as you can see, you don't need to be a statistician or a scientist or a clinician to say that these curves are very similar. So basically, the two drugs are working very similarly in terms of controlling CLL. And as I mentioned, Calabrutinib has a much better safety profile, cardiac-wise, atrial fibrillation, bleeding, including a high blood pressure. So this was an important study. A very similar study, but kind of different, compared zanubrutinib to ibrutinib. And here you see that the two curves are separating, meaning that the green curve, which is zanubrutinib, is better than ibrutinib, which is in blue, meaning that fewer patients are relapsing over time if they were on zanubrutinib versus ibrutinib. So this study also showed that zanubrutinib was better in controlling CLL, and also, as I mentioned, the safety profile was also better. So, here we have two drugs that are both um, great options for patients who have not seen BTK inhibitors in prior lines of therapy, and now they have relapsed disease. We have studies that showed that, for example, if you're taking ibrutinib and you don't tolerate it, so you have joint pain or muscle pain or atrial fibrillation or bleeding or name it, and you finally go to your doctor and say, you know what, I'm done, or your doctor tells you, it's enough with ibrutinib. This study showed that you can take acalabrutinib and those side effects either don't happen, or if they happen at a much lower grade or rate. So it's important to know that acalabrutinib is an option. We also have a very similar study, patients who either took ibrutinib or acalabrutinib in this case, and they had side effects and they had to stop the treatment. They went on zanubrutinib, and most of the side effects either didn't happen, or if they happened, they happened at the lower grade, and there was no side effect that patients stopped ibrutinib or acalabrutinib for, and there was no side effect that recurred at a higher grade on zanubrutinib. So again, the conclusion from these two studies is that if you're taking ibrutinib and you don't tolerate it, you can go on acalabrutinib or zanubrutinib. If you're taking acalabrutinib and you don't tolerate it, you can go on zanubrutinib. So basically, BTK inhibitors are important. You have three drugs. I would say there's no role for ibrutinib today. I would use either zanubrutinib or acalabrutinib. They're both effective. They're both they have a great safety profile. And as I said, zanubrutinib has even uh, been shown to be superior to ibrutinib from the efficacy standpoint. Both drugs have a better safety profile, and just two great options for patients with relapsed CLL if they haven't had these drugs in the past. As I mentioned, if you had ibrutinib or acalabrutinib or zanubrutinib, and your disease progressed, meaning that they stopped working for disease control, you can't switch between the three drugs because they work very similarly. However, if you stop these drugs because you're not tolerating them for side effects, then you can switch between the drug, within the class. Moving on to the next option, this is BCL2 inhibitor. This important drug is called Venetoclax. Venetoclax is a very effective and a very important drug for CLL. It works very well, and it works very quickly, and so quickly that we have to be very careful in starting it. Venetoclax, the target dose, for example, is 400 milligram, as you see in this dark green box here. But we cannot start it at 400 milligram because it would be very dangerous. It kills too many cells too quickly. And what happens in this situation is a syndrome called tumor lysis syndrome, meaning that when you kill too many cancer cells and what's inside the cells gets to the blood, and there is potassium and there is uric acid and there is phosphorus, and these could be very harmful to the kidneys, to the brain, or to the heart, and it could be very, very significant in terms of side effects. So, and because of that, we use this ramp up of venetoclax. We start at a low dose and we go up, and sometimes you need to be, you need to see your team once a week, and in some patients we decide to even have an overnight observation. Again, it's not a new drug, but it's a very important drug, and it's being underutilized in the community because of this just logistical challenges, but it's an amazingly important drug. And one thing I didn't mention about the BTK inhibitors is that the treatment with zanubrutinib, ibrutinib, and acalabrutinib is continuous indefinitely until it doesn't work. With venetoclax, We combine it with an antibody like obinutuzumab or rituximab, and that gives us the opportunity of having a time-limited therapy. We only give it for 2 years in the relapse setting, for example. And with that 2 years, patients stop treatment after 2 years and they go years without needing treatment, which is a very important feature for many patients to have the ability of not taking a cancer drug. So the summary is that if you have a relapsed CLL and you have not seen Venetoclax in the past, this is your other option. Venetoclax-based therapy, it's usually given with a monoclonal antibody like rituximab or obinutuzumab if you can get it. And as I said, it's more work at the beginning, but the it's kind of an investment you do upfront in the first 2 months for the big kind of return of having a time limited or fixed duration therapy for a couple of years and then stop. So I think, you know, the two options are great, either BTK inhibitor therapy with either a Calabrutinib or Zanubrutinib or going on Venetoclax. We don't really know which one is better. They're both great, and it really has to be a discussion between you and your physician. And many factors really are important in terms of what the molecular features are and what are your kind of preferences in terms of being available for making weekly visits to the clinic for the first 2 months or not. And these are type of discussions you will have with your physician. So the first scenario that I mentioned was a patient who had none of the two classes. So I said that you have two options. We have this second scenario of a patient who either had their disease progression on, let's say, a Calabrutinib or Zanubrutinib, or they had Venetoclax for first-line therapy and now they have relapsed disease. So they can, in this scenario, they can use the other class. So the key point is that the first and second in CLL therapy in 2023 has to be BTK inhibitor or Venetoclax. So you know we don't know which one is better. We have some ideas of for selected patients that maybe BTK inhibitor is a good way to start and then follow with Venetoclax in the next line, or in some patients that start with Venetoclax based therapy and follow with BTK inhibitor. Well, that's a topic of conversation and discussion, but we know for sure that for patients who are getting to the third line, we should have already used BTK inhibitor and Venetoclax. So these are the most important classes of drugs for CLL are the BTK inhibitors that I showed you and Venetoclax. So it's important to make sure we have taken advantage of these two drugs. Now, let's move to a more complicated scenario. What if we have a patient who's had both classes? So let's give the example. Somebody started Ibrutinib 7 years ago, and they had a remission for 4 years or 5 years, and then they went on Venetoclax and rituximab, and they finished their 2 years, but shortly after, maybe 3, 4, 5 months later, after finishing their Venetoclax therapy, their disease is back. Not only it's back and it's causing problems. So decision was made to start treatment. We are very limited. I mean, honestly, with all the new drugs, and there's a long list, but you saw that if you lump the ones that work kind of similarly together, we really don't have like 5 or 6 or 7 options. We have two reliable classes that I just showed you. And then we have PI3 kinase inhibitors like idelalisib and duvelisib, which I'm not discussing today because they're used much less common these days for their toxicity profile. So what I'm getting to is that we have an unmet need. And just to remind you, this scenario thankfully is not a common scenario. So patients have a long remission with one of these three drugs and or the Venetoclax. So it's not a common scenario that I have a patient that for whom both classes have failed the patient, right? But it could still happen. I mean, for someone like me who sees a lot of CLL patients, unfortunately, we do have those patients who come to us and they have tried both classes, and their disease has been kind of either refractory or relapse quickly after finishing those. So there is an unmet need. The good news is that recently we have two new drugs, both investigational, meaning that they're not approved by the FDA at the moment. They're expected to be approved, I hope, not having any specific information other than what's public. But like one example is a next generation BTK inhibitor. We call it non-covalent BTK inhibitor. It's called Pier2 Now, from the name, you can tell it belongs to the same family of the BTK inhibitors, like Ibrutinib, Zanubrutinib, Calabrutinib, and now Pier2, right? They sound very similar, but this is very different. This drug is a non-covalent BTK inhibitor, meaning that when it grabs the enzyme that's the target, it doesn't grab it permanently. It just catches the enzyme and releases. And by doing that, and that's one difference. And also it goes for a different point on the enzyme. So the location of the target on that enzyme that this drug uses is different from the three drugs that I discussed earlier. So with these two differences, this drug has the opportunity or gives us the opportunity of using this medication in patients who have already tried ibrutinib or zanubrutinib or calabrutinib and they had progression. I did mention that with those three drugs, you can't move within those three. If disease is relapse, you can't use like zanubrutinib in someone who progressed on a cala. But with Pier2, it's different. We have data showing that you can actually use it, and it actually provides some effective kind of disease control. Just very quickly to show you, this is the kind of map. As you recall, the green, I'm sorry, not the green, the red circle shows your enzyme BTK that this drug targets. But you see how clean this drug is. I mean, there's it's hard to even find those other circles, which are also in red here, but very small and very few. So this tells us that this drug is not only effective because it works differently, it's also very clean. And in clinical experience, it translates to be an effective drug and also very well tolerated drug. And basically, what we saw recently, and the paper was just published actually last night, that this drug pirtobrutinib is effective in patients who had prior treatment with BTK inhibitors or prior treatment with BTK inhibitor and Venetoclax. BCL2 inhibitor is Venetoclax. So, I mean, these are Kaplan-Meier curves. As you see that patients eventually relapse, unfortunately, but you have a median time of around 20 months, meaning that in average, patients, such a high-risk patient population, those who had other BTK inhibitors or Venetoclax, in average, they have 20 months of remission. And when you talk about average, there is a range. So there are patients who had much longer remission. Again, it's for the space of disease treatment that we didn't have a reliable drug. This is a big change, and we are hoping that this drug becomes available, hopefully near future. Another important medication to discuss, and I'll try to give you a little bit more background because CAR T therapy is something that we hear a lot about. And for CLL, despite the fact that in the news you've probably seen a lot about CLL, interestingly, the first patients who were treated with CAR T therapy were CLL patients. And just recently, last year, we had the basically celebration of a 10-year remission of two very high-risk CLL patients who received CAR T therapy. So despite the fact that CLL was one of the early targets for CAR T therapy, CLL is the only disease in the B-cell lymphoma world, or one of the few ones that doesn't have an FDA-approved CAR T. So we are a little bit behind, despite the fact that it started early, but hopefully we're getting there. But what is CAR T therapy? So basically, as I mentioned, T cells are part of our immune defense system. These are soldiers that protect us against infections. They're not uh, when you have a patient with active CLL, it means that the T cells have not done a great job fighting CLL, right? So the idea is to take advantage of these T cells and train them to fight CLL the way they fight infections. So the way it works, here you have a patient. First step in circle number one, you do leukapheresis, meaning that you get their T cells out of their body somehow. These are their own T cells, and you change them in the lab. You basically use either a virus or another technology to induce a gene to patients' T cells. And by doing that, you're modifying the T cell, and you basically put a protein on the surface of the T cell. And with that protein, these T cells are now able to recognize the cancer cell and attack it. I try to show it here a little bit more clear. So here you have the T cell, and here you have the CLL cell. Each CLL cell has proteins on the surface, and they have a name: CD20, CD19, ROR1. These are proteins that cancer cells have on their surface. As you see on the top part of this picture, these T cells don't interact with the cancer cell because they don't have anything on their surface that complements that other protein. Think of it as a key and lock. There are a bunch of locks or keys on the cancer cell, but T cell doesn't have any way of interacting because there's no protein. What happens with CAR T manufacturing process or the genetic engineer is what's in the below part. We put this black piece called CAR, or chimeric antigen receptor. We put this on the T cell, and by doing that, guess what? Now these two are matched, right? So the T cell now can engage or kind of get closer to the CLL cell and attack it and kind of destroy it. So basically, when that attachment happens, cytokines and chemicals that are part of the immune system, they become active, and the CLL cell dies or the cancer cell dies. So that's how this treatment works. It kind of sounds like a sci-fi story, and it is, and it's amazing how it has changed the way we treat lymphomas. As I mentioned, CLL is a little bit behind in development, but hopefully we get there. As you can imagine, this is not as simple as giving a tablet to a patient or a capsule to a patient to take, right? This is a treatment that patients need to go to a center that provides T cell therapy and stay there for a couple of months and get their T cells out, wait until the T cell is made, and then get their modified T cells or CAR T cells infused to them. And you can imagine that immune storm that happens as a result of that immune interaction can cause side effects. I'm not I'm not planning to go through all the details of the side effects, but we have things called cytokine release syndrome, basically side effects from the immune storm that happens. And then we have some neurological toxicities that happen as a result of this CAR T therapy. There's a whole army of people who take care of patients with after CAR T therapy, and there's all science on how to make the side effects better or less common and how to treat these. But I'm trying to give you the idea of this is a new way of therapy, a new way of treating CLL. And just less than a month ago, we had this major presentation and publication that used this CAR T product called Lysocaptogen Morelocel or Lysocell or Beryanzi, which is a CAR T drug that is already approved for large cell lymphoma. But what this study showed that in very high risk patients with CLL, you can expect you can expect long-term remissions after treatment with CAR T therapy, and especially for those patients who had undetectable disease after treatment. Again, a lot of details we don't have time to cover, but I just wanted to give that good news that this is another treatment that will hopefully be available. Again, we don't know; it has to go through the regulatory process, and if available, we will definitely use it for selected patients. One slide on stem cell transplant. We don't use it very commonly these days for good reasons, because our novel drugs work so good that we don't have the number of patients that we used to have like 15 years ago who required allogeneic stem cell transplant. Very briefly here, we use a donor person's stem cell and immune system. And what we do here, we give some chemotherapy or radiation to suppress the patient's immune system, and that way the donor cells will go and do the job. This is an effective treatment, but also very toxic. Unfortunately, 10 to 20% of patients can die from the procedure. So this is not something we want to do unless we have to. But if you do it right, if you select the patients, if you kind of select the right donor, and you can imagine this is another field in medicine that has a whole science behind it, and many transplant centers in the world are working on this. So the toxicity is becoming much better, and it is much better done and tolerated. But I just wanted to mention that that's another option for some patients when they get to the third or fourth line of therapy, and these novel agents are no longer working for them. So just a few examples of clinical trials, and we'll finish in like the next 1 minute or two. So we're using combination studies. I'm using one example for a study that we have, and and there are many other studies in wherever you live. I'm sure if you go to your local expert. So here we're combining Venetoclax and Calabrutinib, two great drugs for CLL, and in the relapse setting here, for example, we give 2 years fixed duration of Venetoclax combined with a Calabrutinib, and we're hoping that that provides a long-term remission. Again, to give you a taste of what is going on in the field, I talked to you about the single classes, but now we're combining them together. We're combining them together in the first line. We're also combining them together in the relapse setting. So this is one example, the Avenue 2 trial, which is acalabrutinib venetoclax for 2 years. And this is studies open and ongoing in Seattle at the moment. Some of the important classes of drugs that are being investigated in clinical trials, we have newer versions of venetoclax or new drugs from that class that are showing very promising results. So just to stay tuned for in the upcoming meetings, we'll hear more about these drugs that are showing very good, effective, basically efficacy and also they come with a good safety profile. We have BTK degraders. These are, remember that BTK enzyme, we're not letting it go. So we target them with the first generation ibrutinib or second generation zanubrutinib or calabrutinib. I told you about pirtobrutinib, which is the third generation, and now we have degraders. Some people call them fourth generation. What these drugs do, they just take the whole enzyme out. Instead of attacking it to at one point, they just take the enzyme and kind of remove it. And these drugs are in clinical trials. I did mention the bispecific antibodies. Remember that the drug that brings the T cell to the cancer cells, and also the CAR T trials. I showed you one example of one CAR T that will hopefully be approved, but CAR Ts come in different flavors and they go for different targets on the CLL cells. And there are many clinical trials that are ongoing at the national level to kind of use the CAR T technology to attack the CLL. I want to make sure we have time for QS questions. So these are my contact information. I'm always happy to answer questions if you have any. Thank you very much. I hope we have time for questions.
Yeah, we have plenty of time for the questions that have come in. Thank you so much, Dr. Shadman, for your presentation. It was excellent. But to all of the attendees, if anyone would like to ask questions, please continue to submit those through the Q&A box on your screen. Just as a reminder, please try to keep your questions as general as possible so that everyone in the audience can benefit from their answers. We will take as many questions as we can before the conclusion of our program today. So starting off with our first question, can you please re-explain the difference between covalent and non-covalent BTK inhibitors?
Yeah, so it has to do with the way, so this BTK enzyme, as I mentioned, is an important driver of cancer cells, right? So, and there are different ways of attacking that enzyme. So the way ibrutinib, acalabrutinib, and zanubrutinib attack the enzyme is just by going for one site on the enzyme and kind of attaching to it and kind of grabbing it and not leaving it. And that way they inactivate the enzyme. The way pirtobrutinib, and then there is another drug called nemtabrutinib, is a little bit behind in development. But what they're like non-covalent binders, meaning that the binding that they make with the enzyme is not necessarily like just grabbing it and not letting it go. They grab it, leave it, grab it, leave it, and by doing that, and plus being able to attach to the enzyme at a different site, that gives them the opportunity of improving the efficacy and working even in settings where other BTK inhibitors have failed to work. So it's just different ways of attacking the enzyme and inactivating it.
Thank you so much. Our next question here is about scenario number 1. Do you take venetoclax in combination with BTK inhibitors, or are you supposed to either take BCL2 inhibitor or a BTK inhibitor?
Very good question. So at the moment, combination of BTK inhibitor and venetoclax is not approved in the US for either first line or relapse setting. As I showed in the clinical trial example that I gave, in the research setting, yes, we do. We combine, for example, we in our institution combine calabrutinib with venetoclax. But if you want to go with a standard and what the insurance companies approve, and and plus, I mean, we have to wait for these. At the moment, it's investigational to combine these drugs. So you either go with a BTK inhibitor as monotherapy, or you go with venetoclax in combination with a CD20 antibody, which is rituximab. And that's the approved combination, venetoclax and rituximab. I would say if you can get the obinutuzumab, which is kind of the better version of rituximab approved from the insurance company, I would give venetoclax with obinutuzumab. But to answer the question, no, we don't combine the two classes of BTK inhibitors and venetoclax in the relapse setting. On the clinical trials, of course.
Thank you. Our next question here is, do you have any thoughts on the effectiveness of Pirtobrutinib in a patient who has previously received a Calabrutinib and obinutuzumab?
Well, I mean, the study that led to the, I mean, I showed very briefly one slide, but I can tell you in patients who had prior BTK inhibitor therapy, response rate was more than 80% in those patients. Now, question is specifically about the Calabrutinib and obinutuzumab. I don't think it would be very different. So prior BTK inhibitor could be Ibrutinib, Calabrutinib, or Zanubrutinib. 80% response rate is very impressive. And as I mentioned, the average time that these patients remained in remission was around 20 months. So yes, the pirtobrutinib drug works in that setting, and it works pretty good.
Thank you. Our next question here is, my CLL transformed to DLBCL after 6 cycles of R-CHOP and 18 radiation treatments. My DLBCL is in remission, and my CLL is not apparently active. But what is the next step?
Well, it's hard to, I mean, I'm making a general, of course, comment here. And I mean, I need more details to answer specific questions. In patients with Richter's transformation who are in remission, if they are eligible for consolidative therapy with stem cell transplant, that discussion should definitely happen. But otherwise, if they're not eligible for transplant, or if they're not interested in transplant, if their disease is in remission, they would be watched clinically and closely for both CLL and Richter's large cell lymphoma. But if they're eligible and they have a reliable donor and they understand the risk and benefit, we always discuss the allogeneic transplant option with these patients.
Thank you. Our next question is, how dangerous is skin staining with a Calabrutinib and Venetoclax simultaneously?
Yeah, I mean, I don't think skin toxicity is a major issue with this combination. Ibrutinib specifically, one of the off-target effects of ibrutinib is this enzyme called EGFR, and that causes rash. And acalabrutinib doesn't actually come with I mean, rash can always happen, but it's not a major or known risk for acala. So the combination, I wouldn't worry about the skin toxicity with that combo.
Thank you. Our next question is, if a person had Venetoclax only as a first-line treatment, can they take it after a relapse with a BTK inhibitor?
If they finish Venetoclax and relapse later and started BTK inhibitor and BTK inhibitor didn't work, or they stopped it for toxicity, can they go back on Venetoclax? Yes. Depending on how long the remission was from the first Venetoclax therapy, the remission from the next treatment of Venetoclax may be, the duration may be different, but absolutely they can go back on Venetoclax.
Thank you. Next question here is, will a patient on Venetoclax continue to have strong side effects throughout the course of treatment?
Actually, Venetoclax is a very well tolerated drug. I mean, it takes a lot of work in the first few weeks to get the ramp up and get to the target dose. But most patients on Venetoclax do actually pretty well. Cytopenia, sometimes we need to support their neutrophil counts every once in a while with growth factors. And really, a small percentage of patients may have some mild GI toxicity. But I mean, in general, patients on Venetoclax do pretty well.
Thank you. And how long has acalabrutinib been shown to be effective for most patients, and what would be the next option recommended if it does stop working?
Well, acalabrutinib has, well, in the first line versus relapse setting, there are studies that show really long remissions. I mean, these are great drugs, and I think we now have for first line, we have follow up from the Elevate TN study of I think closer to 5 years of follow-up, and I would say 80% plus of patients are still in remission. So yeah, I mean, very reasonable follow-up, and patients do well. I think the second part of the question, what I forgot the second part, like what the next options after Calabrutinib could be Venetoclax-based therapy, and when approved, Pirtobrutinib, and these are the two main classes I would consider.
Okay, thank you. And we're going to squeeze in one last question here. This patient writes, since I have been on Venetoclax after obinutuzumab, I've experienced multiple sinus infections, putting me in the hospital with pneumonia, so I'm currently off Venetoclax. Should I try something else since the Venetoclax has made me anemic and neutropenic?
Yeah, sorry to hear that. Again, it's a case by case. In general, I would say some patients on Venetoclax may require, number one, supportive care with growth factor support. Sometimes all you need to do is some dose adjustment, like the 400 milligram may not be the right dose for patients, and uh, commonly we drop the dose in patients who have side effects to 300 or 200. As I said, in general, it's not very common, but uh, those adjustments, I would say. And remember, CLL by definition is a disease that comes with immunocompromised state. So patients may require things like intravenous immunoglobulin support and things like that. And I mean, they can continue along with Venetoclax therapy. So I would say, in general, my strategy is not to give up on a drug like Venetoclax or BTK inhibitors. These are my best two drugs, basically, or classes. So I think optimizing or kind of maximizing the supportive care, those adjustments as necessary, and try to keep the patient on whatever is the right dose for him or her, and kind of use supportive care along that. So that would be my general strategy.
Thank you very much, Dr. Shodman, for answering these questions and, of course, for your presentation. And thanks to everyone for joining today's call. Before we go, we'd like to just again thank our sponsors, AstraZeneca, Genentech, and Merck for making this program possible. Please do remember, if you have any additional questions, you can always reach out to LRF's helpline at 800-500-9976 or at helpline@lymphoma.org. Those are both listed on your screen currently. Also, at the conclusion of the program, you'll be prompted to complete an evaluation. Please do take a few moments just to complete this evaluation as we incorporate your feedback into future programming. But with that, I'd like to thank you all again, and thank you again, Dr. Shodman.
Thank you.
Take care.